Hello, everyone. This is Ryan Logan from the ASG Technology Committee. I'd like to welcome you to another podcast as it relates to our tech committee and the devices for which we oversee in the world of GI endoscopy. The ASG Technology Committee provides reviews of existing, new, or emerging endoscopic technologies that have an impact on the practice of GI endoscopy. We use evidence-based methods, including Medline literature, search to identify pertinent clinical studies on the topic, as well as the MAUDE database to search and identify reported adverse events of a given technology. Both are supplemented by accessing related articles featured on PubMed and by scrutinizing pertinent references cited by the identified studies. We aim to use controlled clinical trials to gather data. However, in the world of GI endoscopy, data from randomized controlled trials are often lacking. In those situations, large case series, preliminary clinical studies, and often expert opinions are used as replacement. Technical data are then gathered from traditional and web-based publications, proprietary publications, as well as informal communications with pertinent industry vendors. With all of that information, the technology status evaluation report is drafted by one or two members of the ASG Technology Committee and then reviewed as well as edited and finalized by the entire committee. Today, it is my sincere privilege to have Juan Carlos Bucobo from Northwell Health, North Shore University Hospital, to talk with us about a recent publication that he co-authored along with Amit Bhatt from Cleveland Clinic on submucosal injection agents. This manuscript will be published in gastrointestinal endoscopy in the coming months. So you should keep your eyes peeled for this in an upcoming issue. With that, I would like to welcome Juan Carlos to the podcast. We're very lucky to have you with us today.
Thanks, Ryan. Thanks for having me today. Good to see you.
No problem. Good seeing you again as well. So the most obvious question and something that we should clearly state is, why we felt like this was important. Why did we think this was important for the ASG membership as well as for the patients that we serve? What's your take on that?
No, absolutely. I think it was a really important topic for me and for the tech committee and for Ahmed to present to our readers and gastroenterologists out there because it's something that's applicable to every gastroenterologist, whether you're a general GI or if you're an advanced endoscopist, in that we're all removing polyps, we're all finding cancers, masses, often have to tattoo lesions for later identification, and oftentimes we're lifting polyps and making sure we're resecting them in a safe, effective manner. And in the discussions with the tech committee, prior publications that had been presented, or prior reports from the tech committee, the last time this was reviewed was over 10 to 15 years ago. So we thought it was time for us to kind of revisit the topic, especially given that there have been so many updates with different type of injection fluids, techniques, in order to educate our readers.
Yeah, I couldn't agree more. I would say that, in my tenure as the ASGE chair and as part of this committee, I think this is one of the documents that I feel is like more important just because it reaches so many people. We're thinking back, not even 10 years ago, we had normal saline, we had some starch derivatives, and that was pretty much it. Um, and now there's so many choices, each of which are a bit different. Um, but we've had a huge surge in proprietary injection agents from different vendors, each with their own kind of benefits and drawbacks. Um, when you look at this document, what are the main take-home points that you and Amit think that the readers should recognize, from our efforts here?
Sure. Thanks. I think it's first when we talk about tattooing lesions, just making sure that you use an approach that is far enough from the lesion, if it's a mass that's going to be, or a polyp that's going to be resected in the future, where it's not causing scarring underneath the polyp. I think it was important for us to really prevent that from happening. We've all encountered, us that do advanced endoscopy, we've all encountered these polyps where you arrive, it's supposed to be a 3, 4, 5 centimeter polyp, and sure enough, there's tattoo that's spread underneath the lesion. So we really wanted to emphasize that as an important point, and just standardizing the technique for those who are injecting tattoo agents to mark lesions, whether it's a polyp that you want to survey in the future after resection, or a mass that you want a surgeon to resect, or if it's the point of maximal insertion after a small bowel enteroscopy, or to identify a bleeding point. Um, Amit, really being the fluid master that he is, really also spent a great deal of time emphasizing the different fluids that are out there, submucosal injection materials that are out there, in order to create those lifts to provide for a safe EMR or ESD. And the different fluids, as you had mentioned, have different properties. Some are more beneficial for certain types of EMRs versus ESD, and it's really important for our readers to really understand the differences and the nuances between the different types of fluids.
Yeah, I couldn't agree more. I think, given now that we have a lot of options, that makes it, as an endoscopist, that much easier to applying a particular submucosal injection agent to a particular scenario. For example, thinking about some of the proprietary materials, they may be great for removing polyps. They may be less good for third space endoscopy.
Right.
Um, and so I think that that's really where the readers should focus their attention when reviewing your document. Particularly, you guys have put all of this in a nice table format, where a lot of this information can be gleaned and people can decide how to apply it best to the patient that they're kind of thinking about. Um, it seems as if most of the agents, while proprietary, have similar things. I think one thing that we should mention is just some of the agents that maybe give more lift and less spread. Some of the agents have some hemostatic factors, which may be included, but also that there's more things on the horizon for different either proprietary agents or formulations. How do you, when you think about in your own personal practice, is your practice mainly polyp resection or third space, or where do you in your practice use submucosal injection?
Great question. I have learned some techniques for ESD, but really don't practice third space endoscopy. My practice is limited to large EMRs, as far as injection is concerned. And for me, it really depends. The size of the polyp, the if you have a laterally spreading tumor, whether or not I'm going to choose one product over another. Sometimes, if it's a very large resection, I'll choose to make my own solution, trying to identify something that's going to lift for long enough, and also that'll have that staying power, and also the right color that makes it easy for me to identify those margins and to identify if I've cut a little too deep or not. Um, Also, the technique will vary, and the solution will vary whether or not I'm going to take out the polyp hot versus cold. So that also will make a difference with my selection. You mentioned normal saline solution, which you're absolutely right. That's probably what most of us started out injecting. And to this day, I still, if I have a smaller polyp that maybe is on a funny fold or doesn't just come into the snare easily, I'll use say normal saline. At the same time, I'll also use normal saline solution if I'm not getting enough of a lift with one of the more viscous solutions. Sometimes just having that, it's easier to inject than some of the more viscous solutions, and it really creates for a lift that, although it might not last long enough, it still has its place. And obviously, needle choice is an important thing to consider when you're choosing a solution and also performing an injection, for EMR and also for third space.
Yeah, those are all tremendously important points. I think needle selection, most people don't give it its due credit for how important it is. My general feeling is some of the needles with a larger kind of core channel, if you will, may sacrifice a little bit of sharpness of the needle, whereas some of the needles that I
Absolutely.
feel are a bit sharper have a smaller channel and may not be great for viscous solutions. I totally agree with the point about normal saline, using normal saline as a boost to a proprietary agent, or even just an agent that's more viscous, is a great technique. And to be totally honest, when I do poem procedures, I still use normal saline. I don't use any fancy solution to do any of my poem procedures, mostly because I can inject additional saline on command, and it's really cheap and easy to use. It is an interesting concept that you brought up a few minutes ago about the exact kind of blue tint that you want, because I think if you asked 25 endoscopists, 25, you get 25 different answers about what color blue they want. Some people want it darker, some people want it barely there. Most people obviously fall somewhere in between. But it's very personalized. And, in some ways that may be a detriment to some of the proprietary agents that come pre-tinted. But it all comes with personal preference and to some degree, perhaps even industry relationships and industry agreements between institutions. So the most important thing is that we have options, and I think that that's what's really key. Um, One thing that I did want to kind of circle back to, because I agree with everything you said, like with every ounce of my being, is tattooing. Um, Tattooing is another thing that, to impress upon, trainees, or people who are kind of just getting into endoscopy, the importance of how to tattoo, and what not to do is really, really critical. As you mentioned, we've all taken polyps off where the polyp is, underneath where, or is over the top of where somebody tattooed, and it's like trying to cut through a crayon.
Right.
It just doesn't work well. When you tattoo, what do you use a specific technique in terms of like actually with the needle? I know some people use saline injection first, followed by tattoo. How do you make sure that you get tattoo where you want it while limiting spread?
Love the question because I'll give you a little example. Did a case last night in the OR where we had a large bowel obstruction, found a mass in the colon, and I had a second year fellow with me. So I asked the fellow to place tattoo distal to the lesion, although initial report he had written proximal. I think it's important to specify in your note where that is that you're tattooing, because for the person that is reading that report, whether it's an endoscopist, a surgeon, they need to know exactly where it is based on what you've written and the photos you've taken. So an important point regarding that. But my technique absolutely matters whether I'm doing it myself or if I have a training with me.
Yeah.
And oftentimes, if it's a fellow that's early on in their training or anybody who's doing tattoo or injection early on, I prefer a little bit of saline first, mark a couple of sites, and then inject the tattoo agent. And the reason that I have them do that is because that limits the risk for peritoneal spread. Having worked with a lot of our colorectal surgeons, they'll come back at times and show me pictures of just the spread of the tattoo agent within the peritoneum. Not that it makes anything more difficult for them, but at times it can cause fibrosis. So it's something important to note. For myself, it's just when I'm injecting, it's a matter of just getting that tangential plane into the mucosa, and quite frankly, I tattoo less frequently because I'm usually the recipient of a lesion with the tattoo. But when I do use the needle to tattoo, I'll typically just get that tangential plane, and just almost like throwing a dart, getting into the mucosa, pull back a little bit, and then inject the solution. Another technique that I find helpful when I'm training the fellows is to actually have them start injecting just a little bit prior to pushing the needle through the mucosa, because that almost guarantees that you'll get that submucosal plane.
Yeah. Totally agree with both of those. Um, Particularly when teaching, to ensure that you're not going to get a whole bunch into the peritoneum. I think the kind of starting to inject before you advance the needle is probably the easiest way to go for trainees. I've even had cases where if I'm with a trainee who's very early in their endoscopy experience, um, where I'll do a saline bleb in the
Mhm.
submucosa and then tell them, okay, now hit my saline bleb and inject tattoo, just so they're able to kind of get a sense of how that should look in the submucosal space when they're done. Because otherwise, if we don't provide appropriate guidance, they put the needle in and they're injecting and nothing's happening, or you're seeing it, disseminate behind the wall,
Right.
then it's a problem for everybody. You're not really doing the patient or yourself justice. So I think that's incredibly important. And I'm really, really glad that the committee spent a lot of time not only talking about available agents, but also, available techniques, because I think that despite whatever agent you want to use or are forced to use or whatever, the technique is really what matters. Whether it's a 15 millimeter polyp or you're creating a 10 centimeter tunnel for poem, it matters, so I think
Absolutely.
that's incredibly important. If you could give the readership one take home point for this paper that they should really take from it, in addition to the tattoo, what would it be for other aspects of submucosal injection?
Um, you know, I wish I could narrow it down to one. I could give you probably a dozen, but let's see. I really think that choosing the right solution for the job is important. There's so many out there that we can utilize, and just finding a comfort with that. So I don't think you and I may differ in our choices for solution, even though we might be doing the exact same job, but it's what you and your staff are most comfortable with. And like you mentioned about choosing the right color, the right tint. If you ask 25 endoscopists, you're gonna have 25 right answers. So it's what's most important to you and you're most comfortable with. And also, I have to mention that what your staff is comfortable with as well. Sometimes having a pre-filled syringe, if you have a busy day where you're taking out numerous polyps in that day, um, having a pre-filled syringe versus making your own solution, you have to justify the cost and the availability and how easy it is for your staff to actually get that ready. So, not sure if I give you one one answer, but I think I give you a couple there that I think would be important for our readers.
Well, those are certainly all good. And your point about the staff and how it relates to your workday and the flow of the unit, in aspects like that is well taken. And probably we don't always do a good enough job as the endoscopist to think about those things. Because it does add time between cases, and it may, add, 15 minutes to your turnover, which over the course of a busy day can add up. So totally valid point, and certainly something that many of us don't always think about. With that, Juan Carlos, I appreciate your time, my friend. Thank you for joining us today on the ASG podcast. Again, to the viewers and the readership, this will be a document available in GIE in the coming months, so please watch for it. Um, and I look forward to doing more podcasts for the technology committee. Thank you again, and we'll stop there.
Thanks, Ryan.